for having me. And let me just start by saying I am ecstatic to have this conversation over lunch, and for me, coffee with you. My only regrets is that I am not live with you face to face, and at least one participant that I know is already online. I really missed the avocado where you're located, and I hope to be back there sometime in the future so we can get together again in a face-to-face setting. So let's launch into this lunchtime session with the next slide. So I am an educator, and so today's objectives are as follows. I hope that over the next maybe 40 minutes or so, we will review population health disparities, just briefly, that impact chronic conditions and the healthcare industry, especially hypertension. I really do want to spend some time, though, discussing opportunities for community and public health to support and improve disparities in healthcare delivery, even in a small island developing country like Barbados, where it's just 166 square miles and a population of just about 300,000 people. And finally, identify opportunities to reduce disparities while delivering direct care to patient population, because this is exactly what we do every day. Next slide. All right, so despite being in what most people would call the ideal place to have a holiday and to vacation and maybe hang out by the beach, many people, many of our citizens are dying from cardiovascular diseases. I am speaking to you across from the University's Chronic Disease Research Center. Interestingly, in this very building, the standardized hypertension treatment protocol was launched, which eventually was birthed into HEARTS. And in the center next door, which deals specifically with chronic disease research, there are two major studies that have been produced. One is the Barbados Eye study that really showed that we have quite a high prevalence of glaucoma and drug-resistant glaucoma. Secondly, the Barbados Registry of Strokes. So like yourself, we are in the stroke belt, and stroke is a #1 killer here in Barbados. We're also, and this is regrettable, the the amputation capital of the world, which we are often referred to as. So it's a very high amputation rate. But look at this, cardiovascular diseases accounting for 31% in the region, cancers 14%, and these are all on the upslope, even post-pandemic. And then other things that are associated, such as diabetes and mental health. So the non-communicable diseases are really having a toll. And if you look at the next slide, which shows you more of a distribution of the countries, some of the countries mentioned, you can see that in the orange, at least the color on my side, the NCDs account for quite a lot of the burden, the disease burden in our countries. Now, the other thing I should say, like many of the countries listed here, as well as some states in the United States, health budgets are not just kind of protected budgets that are only going to be used for health. This is a reality for me during the COVID-19 pandemic, when I had several discussions with ministers of health and government representatives, only to realize, well, you know what? This health budget that was exclusively put aside for NCDs, and in particular cardiovascular diseases and hypertension, now had to be spent in putting up isolation centers and dealing with a national pandemic and task shifting and hiring new individuals. And of course, we are in the stroke belt, but we're also in the hurricane belt. And sometimes finances have to be shifted in many of these territories to respond to national emergencies, climate change, of course, heralding this even more so than before. So we have to do things better, and we have to be able to shift budgets and to do so in a way for the protection of our citizens. Next slide. So the WHO has set forth in 2020 these 9 voluntary global NCD targets for 2025, which, looking at it back then, you might say 2025 is so far off, but it really isn't. It's just about 2 years away. And one is the reduction in premature mortality from NCDs by 25%. Now, I once said, was meant to be under my breath in a faculty board meeting, that everyone in this room, more than likely, this is with colleagues, is going to die from an NCD. And there was, of course, shock. But, you know, the reality that is the case. All we're trying to do is prevent premature mortality. And that's really what our goals are as healthcare professionals. Essential NCD medicines and technologies need to be available. I'll talk some more about how this has led to disparities within my own country during the pandemic and access to essential drugs. Drug therapy and counseling to 50% coverage, and the more active role of pharmacists and other pharmacy practitioners in this regard. Diabetes and obesity and halting the spread. It should not surprise you that 1 out of 3 children in Barbados and in most Caribbean countries, but specifically to Barbados, is overweight or obese. And so there's a national school nutrition and childhood obesity program, which is actually funded by Global Health Incubator through the Bloomberg Foundation. Raised blood pressure reduction, which is primarily what we're speaking about, reduction in the use of tobacco by 30%, salt reduction. Some of you on this call have visited the Caribbean at some point, and you know that our foods are quite spicy, and going to a restaurant and not getting spicy food usually equates to a bad review on TripAdvisor. But getting salt reduction is a serious thing, and every month of May Measurement Month, we launch a campaign to try to reduce sodium, especially along the popular restaurants along our South Coast. Physical inactivity, and yes, we prescribe physical activity, but however, if you don't have the green spaces or even the time to do so, how do you get your patients moving when it's not the easiest thing? One of my colleagues, and I kind of agree with her on this, stated, quite frankly, we are living in an obesogenic environment. So many factors around us that are not as strong as, say, an elevated blood pressure, but simple social determinants of health are out there that are influencing our behavior. We don't recognize this. For instance, I'll just give you one anecdote. Driving home on the south coast of this country, which I said to you has a high NCD burden, and it's only about a 15 to 20-minute drive, you could easily pass at least 10 fast food restaurants. So the usual food chains are mentioned, which are familiar to you. You know, you can see them as you drive by. It's not hard to believe then why you might want to stop in to get fast food. So our environment is obesogenic. And this is married with the fact that healthier foods may not also always be the most affordable. Next slide. Okay, so the NCDs really are the hidden pandemic. If you look at between the 30 to 69 age group, 15 million deaths, which can be largely prevented or delayed, or premature deaths occurring in this group. Okay, so it's a significant burden. 41,000 deaths daily in the world in the age 30 to 39 age group is something for us to be very concerned about. And of course, we're all familiar with the COVID tracker, and which is no longer up, thankfully, because we're no longer in the pandemic surge. But perhaps we are quite stuck in the pan-C-demic curve, which is there in the triangle, where we've become so accustomed to these high rates that we've been slightly desensitized. Next slide. So of course, we knew that the momentum of progress in curbing the NCD epidemic has actually dwindled since 2010. So this is way before the COVID-19 pandemic, but it has been amplified by this, what I would like to call a treadmill for the health system of COVID-19. In order, how do we better respond? And this speaks to Sustainable Development Goal 3.4. Despite considerable progress made in the first part of the millennium in preventing NCDs, the momentum has dwindled since 2010, and the annual decline of risk of dying from major NCDs between the ages of 30 to 70 These are our most productive citizens. And you're speaking about a country, for instance, that is really urgently reviewing our national insurance because we may not have enough productive citizens at work earning a salary to provide for our aging population simply because they're dying from NCDs. So diabetes is showing a 5% increase in mortality. And even pre-COVID, substantial reductions in NCD mortality require strengthening of the health system to deliver NCDs that improve several factors, including improved diagnosis, improved treatment, rehabilitation for those who have experienced or suffered an event, and palliation for those who are at the end of life, including hypertension control as a major driver, and policies that drastically reduce risk factors. I should say that many of these policies, although we see it through the lens of a healthcare professional, really are not within the health landscape at all. They function within the economic landscape, for instance, like cheap and affordable healthy foods, or as I mentioned earlier, the availability of, or the walkability of countries. For instance, are there sidewalks or bicycle lanes where people can cycle to work? What about incentives for eating healthier in terms of insurance premiums? What about other incentives to get people to stop smoking from a public health perspective? So if you want to look at the contrast between our NCD pandemic and our NCD response and compare that to kind of our COVID pandemic and our COVID response with the public health measures, you can see we really haven't been as aggressive in addressing the social determinants of health, or dare I say, the political determinants of health as well. Next slide. So here are three major gaps in blood pressure control. First of all, the diagnosis. Only an estimated 54% of people living with high blood pressure are diagnosed. And of those, 42% of people with hypertension that are diagnosed are actually treated. And this is with pharmacologic treatment. Well, what are the other groups? What are the other 58% doing? Well, some of them are given lifestyle instructions. So, you know, go on and the usual lifestyle prescription, have a healthier diet, get some more exercise, the kind of things you say to patients as they leave the office and hoping that they wouldn't ask you for specific details, which we should be given. And then there's this another group of people who kind of have it, but they actually don't want to start medication. So the physicians have actually tried to get them on drugs, but they've been largely unsuccessful. Now, here's the percentage that scares me. Only 21% of people with hypertension that are diagnosed and treated actually have it under control. You could argue this is probably more our fault, whether we are using ineffective drugs, whether we are feeling there's some physician inertia to titrate medication, whether there is an issue with adherence. If your patients are anything like mine, and I'm sure they are, adherence is not the easiest thing. In fact, I made a comment to a patient this morning in my clinic who came in with a huge bag of over-the-counter medication. She was taking all of them. She said, it's like, well, this is almost like a meal. And then she said to me, you know, doc, I don't feel comfortable taking this amlodipine. It was actually a combination of amlodipine and telmisartan. I said, well, why don't you feel comfortable? Because it's one of those tablets. I said, but you just handed me an entire bag of tablets. So there is a perception. And I know as doctors, we don't want to spend time spending a whole set of time counseling patients, and our nurses do a much better job than we could ever hope to do. But sometimes it's worth trying to dissect the barriers to why patients are not being adherent with drugs. Next slide. This is just a schematic which speaks to the kind of the overarching theme of HEARTS. But just to put things in perspective and to really bring you back to what Pedro Arjunes would have mentioned to you before, HEARTS is really at its very core a simplified set of interventions. So identifying a core set of medications and maybe a treatment algorithm, improve widespread availability of medication, which as we have seen during the pandemic is not always secured. And thirdly, improve healthcare delivery of medication use. In this very room, and I know Dr. Petty is on the call, we had a group of nurses and doctors and pharmacists, and administrators actually. And we asked the doctors in front of nurses, well, what percentage of, do you think your nurses are doing enough in the management of patients with hypertension, such as counseling and making sure they're taking their medication, advising them about titrating regimens, those kind of practices, or even general health advice? The doctors all said that the nurses are working too hard. They're overworked. They have so many things to do in the clinic. They can't possibly burden them to give healthy lifestyle advice. And the nurses responded to the same question by saying, we don't think we do enough. We do a blood pressure, we may counsel occasionally on certain factors influencing, maybe cut your salt or get some more exercise in a more structured way. But we could do a lot more. For instance, we could counsel patients about side effect profiles to look out for medication, and also really get the scoop as to whether they're taking their medication or not. So these are practical things I think as a healthcare fraternity we need to revisit. Is every member on the team that's kind of on the same hymn sheet actually singing the same hymn? Next slide. So the cascade of treatment to improve hypertension control by HEARTS really then focuses on detection and diagnosis of persons with hypertension, treatment among detected individuals, and control among those treated. So those are the three core steps. You could argue that step one is kind of outside of the scope of traditional HEARTS, because it really speaks to public health intervention where these individuals are screened, like interventions like May Measurement Month or other screening opportunities. I made the point that it is inexcusable really in a country with such a high NCD burden for anyone to go to any clinic, even if you're going for a vaccine or whatever, it doesn't matter, and not have your blood pressure checked. If you walk past your polyclinic, as they're called, or primary care settings in Barbados, you should have your blood pressure checked. You would think that if you are attending specifically an NCD clinic that you would have your blood pressure checked, definitely. But only just over 60% of these individuals actually had a blood pressure check when they attended an NCD clinic. Just imagine that you're attending a clinic specifically for NCD, whether hypertension or diabetes or what have you, even obesity, and your blood pressure isn't checked. Next slide. And here are some key elements that can assist with this. Having a hypertension registry, which can be simple as a set of card registry. I know some centers that we visited during HEARTS had a very simplified way of doing this. Validated and comprehensive health registries help you to check on not just patient details, but also control rates. Clinical level performance feedback. I think this needs to be more than just performance feedback, but also some amount of training, such as what we're doing on today's webinar, sitting back and kind of stepping back sometimes and saying, how can we do things better? How can each member of the team be more effective in their role and efficient as well? A treatment algorithm is a no-brainer. We need a simplified treatment algorithm. No one reads the pages of a very thick guideline. Most doctors don't have the time. Nurses, pharmacists really don't have the time to sit to read those long algorithm guidelines. But if there's an algorithm stuck up right in front of them, you're probably going to read it. And then medical assistant visits. In this country, we have increasingly used nursing visits, especially over the last decade. Now, this occurred slowly over the last 10 years, but guess what? In the last 2 years, it intensified. Can you guess why? So in the same country that made it quite clear, oh, we can't have nurses doing more work because they're overworked, and really, it was really just the doctors kind of hammering over, well, this is my area. I don't want it encroached by nurses. During the pandemic, when people are relocated, you want any healthcare professional that is competent and able to follow a simplified algorithm to be available. And in many cases, this was a hypertension nurse who continued clinics as physicians were shifted to other centers to assist with care. And of course, the final point, we're now on to single pill combinations. I'm sure this has been covered by some of the other presenters. Next slide. This is an overview of HEARTS. The booklets are all online and you can have a look at them, but I'm going to move into the next slide, which is a lot more exciting, and maybe we can discuss in a bit more detail. And this is the hypertension clinical pathway. Now, I know that Andres Rodriguez has gone through this in quite a lot of detail, but I'm hoping to give you some practical insights on ways that you might try to even improve this in your own health setting, or certainly have discussions with your patients. So let's look at box A, which is basically a schematic of a person having their blood pressure checked. We make a big deal about this in our setting. In fact, we say to patients, you know, make sure you're using the same chair at home, that you're taking it around the same time. It's almost like a checklist that's done in clinical and nursing school with clinical trainees. And we tick box it as it goes along. And sometimes we observe this in the actual clinic. Quite often, I'm observing a patient using their own blood pressure device in my clinic, and you probably can guess why that is, to prove to them that using the same device, it's possible to get a much higher reading in the clinic simply because you're just in the clinic. And I watch them, and sometimes I'll try to distract them by asking a question and say, no, I'm not going to fall for that, Dr. Connell. No speaking during the measurement, those kind of things. So sometimes it's very helpful to do this. And I would advise everyone on the call, occasionally, whether it's you as the doctor, pharmacist, or nurse, whoever, or even get a relative involved in this kind of making sure that we continue to do things correctly. Of course, standardized guidelines are there, and the WHO guidelines are there as a reference. Hypertension drivers and scorecards, as all countries in HEARTS, and I'm sure soon to be all states in the United States in HEARTS, will be using your scorecards. There are systems for monitoring and evaluation, which allow, for instance, how many patients in the clinic are using home blood pressure monitoring or out-of-office monitoring. How many patients have a cardiovascular risk calculated in the note? How many patients have been given advice about smoking cessation, and it's documented in the note. Those are kind of markers that we frequently check for. Let's move to the next slide. All right, next slide. So this is just showing you a schematic of all of the various points, or let me just say the target audiences for the various components of HEARTS. You should pay attention here that if you look at at who is actually being targeted in some of the packages, especially the evidence-based, access to medication, as well as risk care, and of course systems for monitoring, it's at the national level. So these things need to be put in place at the national or state level. HEARTS would never have been successful in many of the territories that we visited if we did not sit with pharmacists and procurement to deal with how they're going to anticipate changing formulary procurement practices to match treatment algorithms. Or not, we would have an algorithm that was really academic without the availability of key components to that algorithm. Or how are you going to encourage patients to do home blood pressure monitoring if you don't have validated monitors available in your country? Those are things that are serious conversations that you never really think about, especially myself being an academic, kind of say, okay, this is just what we want. But what are the practical solutions or practical barriers that we need to look at to address? Next slide. So the other part of this, which is blown up now for you for a bit more clarity, looks at the risk calculator. Many of you interact a lot with millennials in your practice, or zennials as they like to be referred to. My students are always correcting me, they're no longer millennials, they're actually zennials, a completely different generation, but they're always on their smartphones. And risk calculation really does send home a point, not only to clinicians, but also to patients, that the entire cardiovascular risk profile is being assessed. And it's not just an isolated blood pressure number that may be treated, but we're interested in your entire cardiovascular risk. Next slide. And the treatment protocol, including other things such as the blood pressure targets for starting medication, the use of aspirin, daily aspirin, and high or moderate dose statin, atorvastatin is mentioned here, are also part of the clinical pathway. Next. And finally, discussing those topics that may not be directly relevant to the consultation at hand with a blood pressure, but are so important to the overall mortality of patients. For instance, I know the American College of Cardiology currently has a massive campaign on to get patients living with cardiovascular disease to have their flu shots this flu season. And that's because only about 2/3 of patients living with cardiovascular disease actually have received the flu vaccine. And if vaccination rates in your states are anything like in Barbados, this is kind of a slow uptake for influenza. And people are generally and genuinely vaccine exhausted post-COVID, and they don't want to hear about another vaccine on top of it. Next. And we can go to the next slide. So the WHO guidelines for pharmacologic managed treatment of hypertension in adults, the closing thoughts, lower and lower blood pressure pharmacologic blood pressure treatment protocol thresholds and targets have been used, increasing use of cardiovascular risk in blood pressure treatment decisions, but this shouldn't be an additional barrier to starting medication for patients that meet the blood pressure threshold. The importance of the use of a standardized, straightforward treatment algorithm and protocol has already been emphasized with the clinical pathway. The stronger consideration for the use of 2 medications in single-dose combination pills, and of course, the importance of timely patient follow-up and implementing team-based care. Next slide. So everything was going well until this whole distortion of our health system occurred, which Don DePetty has mentioned on several times during his presentations. The burn-in platform evolved, and the burn-in platform is a great opportunity for us to sit back and look at processes that we think are working well, like public health processes, and kind of make adjustments to make things better. We are all familiar with the next slide, which looks at the various waves seen in COVID-19. What we concentrated on is, of course, the first wave, which was the pandemic wave of acute infections and ICU beds and hospitalization and healthcare burnout. But we never understood completely the impact this wave would have on future waves within the health system. For instance, in my own hospital, and I'm currently back on clinical duty now, our emergency room is saturated, literally, with patients presenting with heart failure. The major driver for this has been, of course, blood pressure control. And many patients during the pandemic have either rationed their medication because of not just unavailability in some cases, but in many cases, they did not want to come near a healthcare institution for fear of getting the virus. Remember, these were the individuals who were told initially, you're at highest risk. So why take the risk of coming to a hospital if you're at highest risk of getting an infection? And so we are now seeing the consequences of what I call the COVID-19 pause, because the NCD burden did not pause. Next. Dr. Tedros sums it up so nicely. He said many people who need treatment for diseases like cancer, cardiovascular diseases, and diabetes have not been receiving health services and medicines they need since the pandemic. And it's vital that countries find innovative ways, not just business as usual, to ensure that essential services for NCDs can continue. Next slide. And this is covered in the next schematic. So I'll go to the next slide because I know we're cutting close for time. Look at how health services were disrupted. Rehab services, hypertension clinics, such as my own, all went on lockdown, were either partially or completely closed. And we had to find ways of reaching out to people to continue their care. Next slide. And the more severe the phase of the pandemic, obviously, the more the health system got distorted because availability of healthcare, HR personnel, as well as essential medicines became a huge factor depending on the pandemic phase. Next slide. And so there was decrease in patient volume due to the cancellation of elective care. In fact, the hospital right next door to where I'm doing this presentation, elective surgeries have only just recommenced after almost a 2-year break. Now, imagine if you or someone needed an elective surgery in 2019, 2020, It's probably less elective now, and many people have to have urgent surgery as a result of these delays. And we don't consider these factors. For instance, the fact that the burden now occurring from the NCD wave in our emergency room is preventing care for people who genuinely have other factors coming into hospital, like a motor vehicular accident or any other emergencies. And so the standard of care in several domains is going to be affected as a spin-off effect. Next slide. Next slide. But there are solutions and there are innovations that we can accommodate and we should uptake so that it's not just business as usual. One such thing is the use of telemedicine or remote care, which I have to admit has been a big pet peeve for me, getting it implemented in my own institution. But of course, when there's no other choice, things tend to get moving. So with the Burn-In platform, all of a sudden, we got all the infrastructure needed, which was already there, by the way, all of the training needed, all of the technical support, and of course, all of the patient training needed to start telemedicine in our clinic. And I'll go to the next slide quickly. Because countries were actually asking for ways of improving NCD management or during the COVID-19 pandemic. And there were several guidance documents given by the WHO, including guidance on how to implement telemedicine rapidly and the use of clinical guidelines. But what made the experience in Barbados so much easier is the fact that we already had in place a system like HEARTS that was able to pivot quickly so that it wasn't learning, for instance, a new algorithm. Patients already knew the algorithm that was being followed. They kind of knew what the next step would be. They knew that if they sent in readings that were not on target via telemedicine consultation, that even a doctor not usually assigned to a hypertension clinic, maybe someone who was reassigned from the child health clinic, for instance, could easily follow the algorithm and know what's the next step in management. And I don't think this is something that HEARTS could have predicted, but the HEARTS protocol has actually improved or allowed for the agility of the health system to respond to a public health emergency, which in this case happened to be a pandemic, but who knows what happens in the future. Take, for instance, we are still at the end of our hurricane season. Many patients will have difficulties accessing hospital simply because they live in rural areas of Barbados and they can't get there if a storm has just passed, right? Many states in the United States have also experienced, because you're also in the hurricane belt as well. And so you have to consider what things can be put in place so that you can easily pivot. I have to admit that whenever I'm planning anything now in the hypertension clinic, I'm always thinking about how sustainable is this remotely? And what happens if I can't get in or patients can't get in? Will care automatically come to an end? Next slide. And these are just some risk factors that overlap. But look at the center of this Venn diagram. Frontline healthcare worker burnout is definitely an overlap, and we all have experienced this, as well as mental health impacts. So the overlapping Venn diagram of indirect systemic factors, direct health system factors, and COVID-19 related factors have all had a major toll on healthcare providers. And we, of course, our mental health and wellness influences the kind of care that we can deliver. And I'm going to go on to the next, I think it's 2 slides ahead, on M health and blood pressure. Next slide, good. So the next slide. Moving into mobile health is not the easiest thing. As I said, you have to determine the patient type. Coaching is necessary. You have to provide support. One barrier that I did not anticipate is the financial barrier of just having a mobile phone or even being able to use it, especially in elderly patients. You kind of assume everyone is going to have access to telemedicine. Setting the agenda, setting reminders, closing the consultation with an agreed plan. Next slide. This just shows some of the attitudes that are necessary for you don't have to be a digital native, but you certainly have to be a digital immigrant to integrate with the technology. Right, having a dry run also helps. Next. The technology network is complex. Next slide. But simple devices such as the one shown here can be used such that you can get information from patients, such as the one on the next slide, without them even coming into the practice. And so I'll close with some takeaway points that COVID-19 represents a contemporaneous and unpredictable public health challenge, but it's also an opportunity to learn. This poses challenges for non-COVID conditions like NCDs. Delayed care will influence mortality related to NCDs, including hypertension and a whole cascade of all the others. Remote management is a possibility for the management of hypertension or high blood pressure. And finally, next slide, telemedicine allows for remote management of blood pressure, but requires some planning and also auditing. Standardized treatment algorithms such as HEARTS reduce the inertia and allow health systems to pivot for both doctor and patient. Mobile health may offer an innovative way to monitor blood pressure and other metrics. And I will close here. I think I'm about